Okay, gang, this is chapter 14. It is really long. There are over 220 something slides. I took out the AMP slides and I got it down to 154, and that's still too much really for one recording. So I'm going to break it up into pieces and record, and I hope that makes it easier for you guys to load it and listen to it as well. So let's get started with general effects of neurologic dysfunction. There are focal effects or local effects, signs related to a specific area of the brain or spinal cord where the lesion may be located. An example is paresis, paralysis of the right arm. There's something then in terms of the left frontal lobe that's causing the paralysis of the right arm. Expanding lesions, growing tumors, hemorrhage, something like that. Any additional impairment is noted as the adjacent areas also become involved with a bleed or something like that, a tumor. Supratentorial and infratentorial lesions. There are supratentorial lesions that occur in the cerebral hemispheres above the tentorium cerebelli and lead to specific dysfunctions in a very discrete area. And there are infratentorial lesions located in the brainstem or below the tentorium that affect motor and sensory fibers. Widespread impairment in this case will occur. Respiratory and circulatory function can be impaired, and consciousness can be impaired. Left and right hemispheres. Damage to the left hemisphere results in loss of logical thinking, loss of analytical skills. You can't do your math. Intellectual abilities, communication skills are in the left hemisphere. The right hemisphere can cause impairment in appreciation of music and art, behavioral problems, as you see in some head injury patients. Spatial orientation and recognition of relationships can be deficient, and self-care deficits. Level of consciousness, LOC. You learn to determine LOC in your first class of nursing, probably. Decreased level of consciousness or responsiveness. There are early changes with acute brain disorders. There are levels of reduced consciousness that can lead to confusion, disorientation, memory loss, unresponsiveness, difficulty in arousal, and loss of consciousness or coma. We're going to talk about some of these. The Glasgow Coma Scale is what we use to determine their level of consciousness. Now, a score of 15 is good. You want a score of 15. You can see in this patient at 0700, they had a Glasgow Coma Scale of 13. So, there were some issues there. Then, at 0900 hours, their score was down to 11. And finally, 2 hours later at 1100, the score was 4. So this person had gone from responding to, their eyes didn't open spontaneously, but they responded to speech. Then, 4 hours later, they're not responding to speech. Look at motor response. They obeyed commands. 2 hours later, they could localize pain. 2 hours later, there was no motor response to pain. Look at your verbal responses. They were confused initially, so they weren't oriented at time and place. But then they became inappropriate in their words, and finally, there was no verbal response. So this patient has become much more gravely ill. Look at vegetative state. We used to talk a lot about vegetative state. They don't say that word a lot anymore, but your book does say vegetative state. It is a loss of awareness and a loss of mental capabilities. Diffuse brain damage is the cause. Brainstem function continues, so they're breathing and their heart is beating. There may be periods of being awake and asleep, but other than that, the person is pretty much unresponsive to stimuli going on in the outside around them. There's something called a locked-in syndrome, and honestly, I have never seen this. It is an individual that is aware and capable of thinking, but they're just paralyzed and can't do anything, can't communicate at all. There are criteria for brain death. And, always be up to date on these things. These things are changing very frequently, it seems like right now, especially. But brain death, cessation of brain function, where the function of the cortex and the brainstem are affected also. There is a flat EEG. There shows no brain activity. The brainstem reflexes and responses are absent. Spontaneous respirations are absent. Without the ventilator, they're not breathing. They can't breathe. One of the things that you continue to look for is the cause. The confirmation, the certainty of irreversible brain damage is determined by the cause. It needs to be evaluated more than once by one person, but at least twice by different people. And everybody has to concur. Motor dysfunction, damage to upper motor neurons. Voluntary movements then are affected, and you may see weakness or paralysis on the contralateral side of the body. Lower motor neuron damage may show as weakness or paralysis on the same side, at and below the level of the spinal cord damage. Decorticate and decerebrate posturing. Severe brain damage is what these indicate. Now, I believe there's a picture. There are better pictures than this. These are not the best pictures, but these are showing you the difference between decerebrate and decorticate posturing. Notice the hands and how the hands are formed and shaped. Look in your book. I think there's a better picture in your book than that one. I know there's one on the videos that I posted on the YouTube channel. If you want to look there at this content, it's a really good video. All right, sensory deficit. Somatosensory cortex in the parietal lobe is where sensory input is received and localizes these things. Mapped by dermatomes. Dermatomes are going to help you to determine exactly where these spinal cord lesions are. Somatosensory cortex. These sensory deficits involve touch, pain, temperature, position, vision, hearing, taste, smell, everything. Visual loss, hemianopia. Depends on the site of damage in the visual pathway. The optic chiasm is damaged. Vision is lost in both eyes if it's totally destroyed, and partially lost, but it depends on particular fibers that are damaged. So the optic tract or occipital lobe damage, there's loss of the visual field on opposite side to that of the damage. So this is a great little diagram that shows you visual field loss based on the nerve and how the damage is perceived here. You see the crossover, the optic chiasm, the tracks. Language disorders. Aphasia. Now, barking you hear is 3 puppies that I rescued. Anybody want a puppy, let me know. I'll meet you. Aphasia is the inability to comprehend or express language. It may be receptive, indicating damage to Wernicke's area. It may be expressive, indicating damage to Broca's area. Or it may be mixed, indicating damage to both areas. Dysarthria is motor dysfunction that affects muscles used in speech. Aphasia. There are different types. You see the expressive, receptive, and global, and that's what we just talked about. And the Broca's, Wernicke's, and in both areas affected, and how they're affected. Expressive, they can't speak or write fluently or appropriately. Receptive, they don't understand what you're saying. And then global may be both. Other things, expressive or motor aphasia. Impaired ability to speak or write fluently or appropriately. This is the Broca's area we talked about. Receptive or sensory aphasia. An inability to read or understand the spoken word. It's not processed in the brain. This is usually the result of the Wernicke's area we talked about. Global, we said, combination of both. Major brain damage, both areas affected, lots of communicating fibers affected. Fluent or non-fluent aphasia. Fluent aphasia. The pace of the speech is normal, but the words don't make sense. So this is associated with damage to Wernicke's area. And then there's non-fluent aphasia, where things are slow, more labored to get the words out, short phrases, and this is associated with Broca's area. Dysarthria, where the words cannot be articulated clearly. There's motor dysfunction, usually from cranial nerve damage, but it can be from muscle impairment. And there are some other things here just to know. Agraphia, impaired writing ability. Alexia, impaired reading ability. You sure you don't want a puppy? Agnosia is a loss of recognition or association. Let's get to seizures. Seizures are convulsions caused by spontaneous excessive discharge of neurons in the brain. What causes this excessive discharge? Inflammation, hypoxia, bleeding in the brain. There can be focal, related to the particular site of the irritation. They can become generalized. Lots of times what we see is an aura or an abnormal sensation. And that's when we see those repetitive movements, involuntary. My brother has seizures. He had meningitis as a child, and he had seizures. And what he will do is start to smack, and sometimes he will just say, yeah, 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 yeah. And when I'm talking to him on the phone and he starts saying, yeah, 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 to everything, I know he's having a seizure. Generalized absent seizures, petit mal seizures is what we used to call these. These are maybe tonic-clonic or myoclonic. They're also partial seizures. There are simple partial and there are complex partial. And then there are continuous seizures, and that is status epilepticus. It is a life-threatening emergency. We need to do something to get this stopped. Read more about these in your book. These are important to be able to distinguish, and you will definitely take care of patients having seizures no matter where you work. Increased intracranial pressure. Remember that the brain is encased in a hard shell. The skull does not expand, it doesn't breathe, it doesn't stretch. So the fluids, the blood, the cerebrospinal fluid, everything up there in that skull isn't compressible. And so what's left that is compressible is your brain mass. Increase in fluid or additional mass causes increase in pressure in the brain. Infarction of brain tissue. There are lots of neurological problems where ICP is an issue. You will see and read and hear and study more of these when you get on into med-surg. But there are brain hemorrhages. There's trauma. Lots of different things cause head trauma. Edema, cerebral edema, infection, brain tumors. any abnormal circulation of the cerebrospinal fluid. You will study all kinds of things about these. Early signs of increased ICP, if we don't do anything about it, the level of consciousness is going to change. They won't be as responsive. They'll become lethargic. Pupils won't respond. Headache, severe headache. Everything is stretching. Vomiting, sometimes projectile vomiting. If you've not seen it, you'll know it when you do. It will project across the room. Not associated with food intake, and it's a result of this pressure on the emetic centers in the medulla. Papilledema. This is swelling of the optic disc, and you'll see this by looking in the eyes and doing an eye exam. Here's a great chart that lists all the things we just talked about. Go back and look at this. I love charts. This is a nice, easy way to learn things. And this is why I always tell you in the book, go and look at the charts and the diagrams and the highlighted and underlined words. This is a great way to learn and to see what's important. Other things, increased intracranial pressure, vital signs. Vital signs will change based on what's going on in the brain. With the development of cerebral ischemia, everything, vasomotor centers are going to respond to try to increase blood supply to the brain. Systemically, everything will vasoconstrict to give more blood to the brain. The baroreceptor responses in the carotid arteries, they're going to increase blood pressure by slowing the heart rate. Chemoreceptors respond. They're going to respond to low carbon dioxide levels and reduction in the respiratory rate. Improved cerebral circulation will relieve the ischemia, usually for a short time at least, because we need to know what's causing this. Increasing ICP is going to cause it to come back, and it's going to repeat all over again. So here's a nice little diagram of vital signs with increased intracranial pressure. And you can see that they are attempting compensation and finally get to the point of irreversible damage. You see the increasing pulse pressure there between the systolic and the diastolic blood pressure. Visual signs, you'll see pressure on the oculomotor nerve affect the size and response of pupils. The pupil ipsilateral to the lesion becomes fixed and dilated. Shift of contents across the midline, both pupils become fixed and dilated. And ptosis, that droopy eyelid may occur due to effective pressure on cranial nerve 3. Herniation, finally, transtentorial herniation or uncal herniation. Transtentorial is within the cerebral hemispheres. Diencephalon, midbrain are displaced down. The resulting pressure affects the flow of blood, CSF, REF. It affects respirations. Uncal herniation, the uncus of the temporal lobe is displaced down. Pressure on cranial nerve 3, the posterior cerebral artery, and the RAS. Infratentorial herniation, or tonsillar or cerebellar herniation. The cerebellar tonsils are pushed down through the foramen magnum. This compresses the brainstem and the vital centers, causes infarction, and causes death. What are diagnostic tests? Computed tomography scans, MRIs, all the things that you probably have already known and studied. Radionuclides can be used to track perfusion. An LP, a lumbar puncture, can be used to check the cerebrospinal fluid and see what's there. Are there tumor cells there? Are there blood cells there? What's going on? And to check the pressure. I have seen an LP, normally when you do a lumbar puncture, you put the needle in, remove the stylet, fluid will just slowly drip out. I have seen it shoot out from the pressure. Let's stop here, and I will make another recording.